Hello, it's very nice to be with you today. My name is Philip Lodge. I'm a consultant in palliative care at the Royal Free Hospital and Curie Hospice in Hampstead. I'm going to talk to you today about the role of palliative care teams in the care of patients with neuroendocrine disease. I hope I can be reassuring as well as informative. I thought I would start with the World Health Organization definition of palliative care and to emphasize the fact that we should be paying attention not just to the physical aspects of illness, but also to the psychological, spiritual, social issues that arise. And perhaps palliative care services are able to provide what might be called holistic care, where other teams and indeed general practitioners just really do not have the time to devote to that. They need help, and hopefully we'll be there for that. Important to emphasize again is that there is no particular time during the journey through an illness where we should or shouldn't be involved. It is dependent on individual need. Symptoms can arise with treatment, even in the curative setting, that we can be helpful for, and I think we should be open to that. Palliative care services should be available wherever you live. There will be some variation in what is on offer, and there might be also some variation in what kinds of problems they may accept. However, I think the symptom control advice should be there irrespective of where you are along the course of your disease, whether you're having curative therapy or, shall we say, disease modifying treatment. It shouldn't matter. Palliative care services cover hospital, community, and of course hospices. Like many of you have already experienced in neuroendocrine teams, the mainstay of palliative care services are clinical nurse specialists who will be supported by a wider team including doctors. I'm sure you've all hopefully had some good experiences of clinical nurse specialists who, after all, are much more approachable perhaps than doctors. Don't say it to anyone. In terms of when it might be good to have a palliative care team supporting you, clearly the physical symptom control side is absolutely vital. However, it may also be for the emotional psychological support, and not just for the person themselves but perhaps for their family. Advanced care planning is thinking about the future and how you would like to be cared for is something that we often discuss and make a plan for. And then of course there is end-of-life care. I think it's really important to get rid of the phrase "there is nothing more we can do." There's always something we can do, and it is not the case that palliative care teams become involved when there are no more oncology therapies. That's not right. Triggers for referral may sadly be progressive disease. It might be an acute complication. It might be repeated hospital admissions because of functional decline, or perhaps worsening symptoms. Sometimes it is patient request. Entirely valid. We do not necessarily keep you on forever. If you become stable, improve, then we may well discharge you, and if at some time you need us again, we will still be there. There is a concern amongst patients, families, specialists that referring to palliative care is almost a guarantor of something going wrong. I think it's very difficult to get rid of the association between the phrase palliative care and perhaps the word hospice and end of life, but we do see people at every stage of disease even those having curative therapies. And I think this study was helpful to try and dispel some of the concerns. It was carried out in the United States looking at patients with advanced lung cancer, where a group was randomized to receive, as it were, palliative care alongside their standard cancer therapy versus a group who had the standard cancer therapy alone. What they found, quite surprisingly, was the patients who were referred to palliative care lived longer, had better quality of life scores, anxiety, depression scores, and so on. Clearly this is a study that will probably never be repeated, but hopefully it is a little bit reassuring that palliative care can be helpful. Practicalities around referral hopefully are straightforward. Any member of the neuroendocrine specialist team or another hospital team, a GP or district nurse, are able to refer. Where we are referred patients to follow up at home, we will make sure the GP is happy for us to do so if they were referred by someone else. Otherwise, it should be very straightforward. You are allowed to give your teams a nudge if you feel you would like to see someone from the palliative care team. It's absolutely fine. I'm going to talk a little bit about pain control, which I'm sure can be a difficulty for many. This is a representation of the World Health Organization analgesic ladder. It was developed in the 80s, really for use across the world, including the developing world, where the emphasis would be on oral medication, and indeed the kinds of medication that were widely available, hopefully. It could be criticised now because we have different methods, different procedures and so on for pain control. However, it's still a reasonable place to start. Opioids are not the easiest drugs to use, and of course will be to a degree stigmatised by what we know about them in terms of illicit drug use, scary stories like we've read regarding patient experiences. However, there's no getting away from the fact that if your pain is no longer responding to paracetamol, anti-inflammatory medications, if you can tolerate them, then opioids will be the next step. And really, we don't have anything better currently. We have to manage the adverse effects, and hopefully the benefits will outweigh those. And if they are used, prescribed, administered within guidance, hopefully they will be helpful. Side effects are difficult. I've put them pretty much in order of what patients say to me cause the most trouble. Constipation is clearly number one. Drowsiness, difficulty concentrating, and memory difficulties make a significant impact. I think the other four are much less troublesome for most people. It's really hard to get away from the association between the use of opioids and dying. Clearly, as patients deteriorate and their symptoms perhaps worsen, we will use more opioids, and inevitably this leads to a question about, are we hastening death? It's really difficult to disabuse you of that, because to design a study that would prove it would be, I think, ethically impossible. There are some studies in the literature which might be helpful, and I've listed them there. I think it's safe to say that we don't have evidence either way. Intuitively, if someone has uncontrolled pain, they don't eat well, they don't sleep well, they are not physically able to do as much, I fear that they will be deteriorating quicker than if their pain is well controlled. And that's my approach. Addiction is another big question for patients and families. It's really important to emphasise opioids, once you've been on them a while, should not be stopped suddenly, because you will develop withdrawal phenomena. This does not mean that you have become addicted. It means you have a physiological dependency, just as you would if you were on steroids or some other drugs like antidepressants or even some anti-blood pressure medications. It's important to make it clear addiction is defined by behaviours, drug seeking, life being dominated by the need for the drug, and so on. Alongside this, tolerance is important to mention. That is the entity of essentially needing a higher dose to obtain the same analgesic effect. That can happen, certainly for many people, and it's manageable, but it does need to be openly acknowledged. So, will you get addicted? No. Hopefully, that's a bit reassuring. Opioids in overdose, where people have a large amount suddenly, perhaps on a background of no previous use, will cause you to stop breathing. That's true. However, when used on a regular basis, by mouth, under guidance, it's absolutely rare to experience this. We use opioids commonly to actually relieve the sensation of breathlessness in many conditions of the lung and the heart, as well as shortness of breath related to cancer. So they do not help patients by slowing down the breathing or stopping their breathing, and it's really important to reassure you on that. Many people ask me now about cannabinoids, cannabis related medicines for pain and other symptoms. Sadly, despite what might be said in the media and in the Houses of Parliament, there is no product that I can prescribe on the NHS for pain. The evidence is actually sketchy. Again, despite what you may read in the mainstream media or on social media, there are many claims out there which we as yet do not have the evidence to back up. There are private clinics in London, in other cities in the UK, where you can obtain products that we can't yet prescribe, or indeed cannot be bought over the counter. But I could not say where their place is in terms of treatment, or indeed how to use them. That's yet to be worked out. So I wouldn't say don't do it, but I can't say please do it. Hospice care is probably another slightly anxiety-inducing phrase. I'd like to again reassure you that it is not solely for people who are sadly dying. However, can be helpful for people who have hit really difficult symptoms that need controlling, or that need hopefully rehabilitating or help with adaptation to a new disability following a complication. We also can offer respite care where people need significant assistance at home and a family or formal carers need some help with that. There is, of course, the role of end-of-life care. In terms of people living with neuroendocrine disease, of course you may well benefit from palliative care services. I think it is right to acknowledge the barrier, which is the implications of both palliative care and the hospice word. I do think that sometimes we as clinicians don't recognise that there might be some benefit, and therefore don't make the referral, and there's still the misperception that palliative care services and hospices are only for those who are dying. I mentioned this earlier, that services around the country will differ in their criteria for referral, so that can be an issue, I appreciate. I'm going to tell you a story now, really to just illustrate some of the things that I've spoken about. And this is someone I knew very well, who a long time ago was found to have a lung neuroendocrine tumour. She was married, she had two, at that time, fairly young children, and she was a special educational needs teacher. She went through, as you can see, probably all the various therapies that were available at the time: FCIS chemotherapy, radioisotope therapy, embolization. She went on to have significant surgery to remove liver metastases and a left lung lobectomy, radiofrequency ablation again, more radioisotope therapy and more radiotherapy in the form of cyberknife to bone disease. And it went on. As you can see, she really went through the whole armamentarium, I think. She was referred to palliative care as an outpatient 2 years after diagnosis, and right from the outset she was well aware that all her treatment was aimed at really controlling the disease, and sadly we were not able to cure her, and she was very open to talking about the future and the what if questions, and made sure she had a valid advanced decision to refuse treatment, which was very important for her. The symptoms she experienced were many, which I'm sure some of you have experienced or continue to do so. Pain, fatigue, shortness of breath, nausea, vomiting, an erratic bowel habit which lurched between diarrhea mostly, but also constipation. Anxiety, particularly when coming up to scans or more treatment. She went through many different approaches for her symptoms, and some of the medications she used included oxycodone, diazepam, many anti-sickness medicines, and things to try and slow down her bowels. She came to see me in the outpatient clinic at the hospice, and she felt really that that would be the place she would wish to be cared for at the end. Many years after I first met her, she did finally start to become less well, and it was really about daily life and what she was able to manage. She spent more and more time either in a chair or bed. She struggled with those normal daily activities, preparing a meal, doing the laundry, all those things we take for granted. Even then she remained on therapy, despite her very open views on, life was not worth living no matter what. She never really got to the stage of stopping therapy. She talked about it many times. During that year she was referred to my community team, so we could see her at home, and then finally at the end of 2019 she really did change in terms of her physical functioning, and the chemotherapy was stopped really because it was no longer helping, and it was quite clear that she needed symptom control and support at home. She changed her mind about where she wanted to be cared for. Her family were absolutely with her, which was helpful, of course, and that's where she stayed, with her family at home, and fortunately we were able to obtain 24-hour care for her, and managed to keep her where she wanted to be. So I hope that was a little bit helpful. I hope I haven't scared the bejeebers out of you, but I want to talk a little bit about the future. I think in my career lifetime, anti-cancer therapies have just expanded so much that patient expectations and my expectations of the patients have changed significantly. People live longer and hopefully better with their disease. However, that may mean that they live longer with symptoms that are difficult and perhaps difficulties with daily tasks, and we need to think about how we support more and more people with those issues. At the moment, I don't think there is a provision of more resource, either for symptom control of the physical side or the practical ongoing care, and it's a challenge. So please don't be scared if someone says to you it would be good to see someone from the palliative care team. Hopefully it will be not just helpful but extra to all the care and support that you will receive from your treatment team. And I hope that this has been a little bit helpful. Thanks very much for listening. Bye bye now.